I think it's good attendance, everyone. Welcome back after Eid al-Ramadan. كل عام وانتم بخير. It's a pleasure actually being here tonight with two of my dear colleagues and friends. I don't want to say my students, so you don't think that I'm old enough, but they are really dear, and we share a very interesting subspecialty, of course, heart failure as well. The topic today is as interesting. We are going to talk about hypertension, and I'm glad that we are getting more and more interest recently in hypertension. It's a silent killer, as they say. Many people are not aware that they are having hypertension, and if they do know, they are sometimes not well treated. So more awareness about hypertension is necessary. Um, best of management is also very important to recognize. And the updates, there are lots of new work on hypertension, which is nice to see coming into the active world recently. Without further ado, I would like to start with our first speaker, Dr. Ibrahim Julaydan, who's a consultant cardiologist at National Guard Jeddah, and will give us an overview about hypertension in general and in Saudi Arabia. So please, Dr. Julaydan.
Thank you, Prof. Walid. Thank you also, Dr. Ismail, for sharing the session with me. It's a pleasure to be with you guys, sharing the same interest in heart failure, and also it will crossroad with the hypertension, given the hypertension is one of the major risk factors that will lead to significant cardiac disease, including coronary artery disease and heart failure. So hopefully everybody is seeing my slide. Is it clear?
Yes, it is.
Okay, so it's not a long lecture, so I'll try to be concise. In the next 20 minutes, I'll try to focus on some practical questions. How large is the hypertension problem in Saudi Arabia? And then in general, not just in Saudi, how well we're doing in terms of controlling hypertension patient, and what are the factors that usually lead to poor control, touching briefly on the classes of management or the approach of management, but probably we'll need more prolonged lecture if you want to go deep into the diagnosis and the management in details. So first, all we know that hypertension is a global public health problems. The data worldwide is astonishing. So it's one of the it is the leading cause for a premature death globally. When we're talking about a population of 8 billion, almost 1.2 billion, so that's a huge number of population affected by hypertension. And they don't usually have hypertension alone. They usually have multiple comorbidities that will coexist with hypertension, like CKD, heart failure, diabetes, and coronary artery disease. It's either leading to or coexisting with, and that will increase and sharpen the problems. So 1 in 5 adults receiving hypertension treatment are uncontrolled, and that's a major number. So when we talk about 20% of the patient are not controlled, that will contribute significantly to the worst outcome to the patient, and that will lead to the increase in the global healthcare expenditure, because those patients will have a poorer outcome than the managed population. And if we look at Saudi Arabia, there's a lot of data, but there's a systematic review and a meta-analysis that was recent in the 2023 showed that the prevalence among adults in Saudi Arabia is around 22.7%. So we're thinking about like 1 in 4 people walking in Saudi Arabia will have hypertension, and it will increase with age. So if we look at people who are above 65, it's almost 1 in 2. So it's a huge problem. It's affecting a little bit men more than women. And when you look at the Saudi data, there you will find a lot of variable numbers in terms of the prevalence, probably because of the methodology. For each study, some studies that I looked at, they look at self-reported diagnosis, some look at the accurate measurement. Some use different cutoff for age, but it does not mean that that's probably why some of the numbers are different than the global numbers. But eventually, it's a major health care problem. And if you look at the diabetes, for example, I don't recall the number exactly, but I think in the same realm of 24-23%. So these two by themselves are occupying a big portion of our population, and we need to take care of it more and more. And if you look at the WHO data that's reflected in Saudi Arabia, or the Saudi Arabian slide in the WHO data, you can see the problem that we have is probably what I can point to is the figure on the right upper part of the screen. So if you look at our population, it's not just we have 1 in 4 have hypertension, but half of them are not diagnosed. So that's a big problem. So you have half of your patient are not picked up with the accurate diagnosis, and then a lower portion of the patient who are treated, and even lower who are controlled. So that's a major problem that we are facing, because hypertension can associate, as we said, with a worse outcome in those populations. So if we are not diagnosing or not treating appropriately and not controlling the hypertension, probably the outcome data will be much worse than probably the global data. And if we look at why, probably why people are not controlled, or what are the other risk factor and the environmental factor that will lead to hypertension that will increase the burden of the problem. I will not read this list from the slide. Instead, I will just use it to frame the Saudi hypertension as a part of a large cluster of metabolic and behavioral risk. In real clinical life, people also will have genetic disposition, they're overweight and obese, they have a lot of sodium intake, issues with physical fitness, probably not alcohol in our community that much. We'll have coexisting modifiable risk factors such as tobacco, diabetes, dyslipidemia, obesity, inactivity, and poor diet. And we do have some non-modifiable risk factors that will lead to increase the problem, like chronic kidney disease, that can coexist with hypertension and actually can make hypertension worse, actually, in terms of the management. Family history, some genetic predisposition factor. And obviously, we have to make sure that we understand the secondary causes for hypertension to make sure that we're not missing those factor that will contribute to the disease itself. And if we look at the different etiologies, it will just make us think that hypertension is not just a single pathway. It reflects there is an interaction among multiple pathways. There is renal sodium handling issues. There is increase in vascular tone, autonomic dysfunction with the autonomic drive, endothelial dysfunction affection, and also neurohormonal system disturbance. So we have multiple pathways that will lead to hypertension and contribute to the hypertension of the patient. So basically, when we treat the patient, usually we look at multiple aspects. We don't, and we need to look at a more holistic approach to the patient. And that's probably why when we talk about the management later on, we try to approach multiple pathways at the same time. One of the pathways that probably also I will mention briefly, but Dr. Ismail will mention as well, is the aldosterone secretion and the renin-angiotensin system pathway. So we all know this from physiology. The renin-angiotensin system is one of the factors that will have bad sequence on the vascular smooth muscle, and will also cause a lot of issues with the kidney function. The end of the pathway will cause the adrenal cortex to secrete aldosterone that will also contribute to the side effect or to the negative feedback from this pathway. Usually the effect of the aldosterone secretion will cause sodium channel disturbance, the vascular smooth muscle profilation, and that will cause to more of the increasing the tone that will affect the blood pressure control, will cause more fibrosis and remodeling, and increase the oxidative stress. So all of that will affect patients with hypertension. So that's why it makes sense when we manage patients, we look into this pathway also in particular, and probably that's a more discussion of the next lecture. So now understanding the burden of the disease globally in Saudi Arabia, why we really care about the burden of the blood pressure, because it's really associated with worse outcomes. So the graph is reinforce a simple and clinically useful principle. The cardiovascular, The cardiovascular risk continuously increase with systolic blood pressure being uncontrolled. There is no reassuring plateau. It's not going to go down with time. It's just keep going up when the blood pressure is not controlled very well. And this is probably, sorry, let's just keep flipping. This is also international data, but this is probably also will reflect on the Saudi population, especially with having multiple other risk factors like the high incidence of diabetes, the high incidence of other like the obesity. Like I'm not sure if I'm having an issue with the slide flipping, but bear with me. So all those risk factors will cause this graph to increase even more. And if we look at the kidney function, it's also very important because this slide reminds us that the elevated blood pressure contribute to both the developmental and the progression of chronic kidney disease. In practice, also, the kidney is both the victim and the contributor. I'm not sure why it's keep flipping. Okay. So the kidney function usually, when it's affected by hypertension, but also when chronic kidney disease start to happen, that will usually worsen the control of the hypertension, make the choices of the hypertension medication very limited. In Saudi setting where diabetes and obesity are also common, this interaction will become even more important. So good hypertension control, including an appropriate diagnosis and monitoring to the patient will lead to better control for our patient. More broadly, as I mentioned, hypertension behave as a complex condition. So it's not only, as I mentioned before, we're not only managing one system, and not all hypertensive patients are the same disease. Some patients are predominantly sodium sensitive. Some of them are obesity related. Some of them are driven by chronic stress, poor sleep, medication affect autonomic tone dysfunction. Obviously, some of the behavior risk factor will affect the patient. Some of them will be affected mainly by some of the secondary hypertension causes. So the idea is we have to look at it at the holistic approach. We only manage, we try to individualize the patient management plan, but we have to look at the patient from all aspects and not just focus on one aspect of their disease. And we know that every reduction of the blood pressure will protect your heart, will decrease the risk of stroke, will decrease the incidence of heart failure, and decrease all-cause mortality. So even modest decrease in the blood pressure will lead to important reduction in the patient clinical outcome. That was reflected. I know those trials are now a little bit oldish. They were a little bit newer maybe when I was in training, but the idea, I'm not going to go through them in details, but those trials kind of drove us a little bit to more controlling the blood pressure to a lower target level. So if you look at the SPRINT trial that showed when they looked at the strict blood pressure control below 120, there was a reduction in the cardiovascular event and death. In the ACCORD trial, although the primary endpoint was not reaching the statistical significance, but the endpoint of stroke was significantly reduced with controlling the blood pressure very well. And that reflected on the guideline after that. So if you look at multiple guidelines, those are a little bit older American guideline in 2017, you can see that the class 1 or the green recommendation for the patient to control the blood pressure less than 130/80. And if you look at the European guideline, they have a similar target in terms of the control. You may individualize your patient care for the patient if they are elderly and frail. Sometimes you can take a little bit less tense approach. But the idea is if those patients really cannot tolerate the medication, you don't want to cause more harm. But if you're able to do the medication to those population with no side effect and they are tolerating it very well, it's actually reasonable to meet the same target for blood pressure. I think it's simple right now and it's not complicated. It's not different between different disease sector. If we look at the Saudi guideline recommendation, this is mainly for the definition and recognition of hypertension. You may go to the Saudi guideline and look for also for the targets, which is similar to the universal target, but we do have a clear cutoff for diagnosis right now from the Saudi guideline. So, and we need to know the exact appropriate way to measure the blood pressure and the appropriate cutoff for diagnosing the blood pressure in different setting, either the office setting or the ambulatory setting or the nighttime reading in the ambulatory setting. And the idea is you need to be thorough with your patients. So seeing a patient once or twice with a reasonable blood pressure or a little bit elevated, or accepting a patient. I see a lot of patients in the clinic walking in with 140/90 and been seen by multiple physicians and been accepted. I think it's not accurate if we look at those extensive cutoff measurement, and a lot of the way to diagnose blood pressure, we need to be very vigilant about it and don't let the patient walk without having a clear diagnosis and a clear management plan. I'm not gonna delve a lot into the treatment. Of course, we need a different lecture for that. But the idea is, if we look at multiple treatment algorithm, maybe we choose a little. The European guideline is a bit more recent, but the Saudi guideline are similar in a way. So most of the patient we're looking at low dose double combination therapy. As I mentioned before, we have multiple pathways, and we need to control multiple pathways to assure better control and actually control the blood pressure more, and also decrease the side effect profile. And if you can see in the box in the top left, that the initial monotherapy only preferred for certain populations. So patient with really stage 1 hypertension maybe, or like really mildly elevated blood pressure, or moderate to severe frailty. So it's not just any elderly will give me monotherapy. You need to have a significant frailty, like a very significant age, more than 85, or people with symptomatic orthostatic hypotension. Other than that, actually, we really need to start with multiple medications. So the single pill combination is very good approach that I usually start in the clinic. Fortunately, a lot of the governmental hospitals, they don't offer the single pill combination, but usually I combine two classes of medication. And the idea also that you need to assess the patient very closely. So it's not good to start a medication and see the patient in a year time. You need to be a little bit more vigilant, seeing the patient in a span of 1 to 3 months. Usually those medications take some time to work, but 1 month to 3 months seems to be reasonable. Then you can add either a third medication with the combination approach, or increase the dose of the combination therapy, and then go down the algorithm as mentioned. And uh, as I mentioned, this is in the European guideline for the management, so you always can go to it. You have more resources to use if, in case your patient, you offer them the multiple medication, they're still having resistance, and you rule out secondary causes like the spironolactone that's mentioned right now in the guideline. And there's a lot of newer medication that will make its way on the market, especially the non-steroidal and the aldosterone inhibitor medication that we'll be probably talking about in the next lecture. The important issue that hypertension will mediate organ damage. So uncontrolled hypertension, why we care about that? Because hypertension will cause a lot of problem. It's not only one system, it's multiple system. You know, it's from the brain, visual system, the heart causing LVH, diastolic dysfunction, bile A and LV dilatation, AFib, obstructive sleep apnea, myocardial infarction risk, and heart failure at the end. It will can affect the kidney function. It can affect the microcirculation. That will lead to increased risk of stroke as well, and peripheral vascular disease as well. So it's really important to look for end organ damage in those patients. So how we do that, I'm not going to go also through the whole slide, but the idea is you need to be first of all vigilant with seeing the patients. So individual who are having uncontrolled blood pressure, or you're visiting you in the clinic, you have to think about multiple organ damage screening. So for example, the kidney function, we do measure the microalbumin creatinine ratio. We do measure the creatinine for those patients. For the heart point of view, it's very reasonable to do the ECG, look for any LVH sign. I personally do echoes for all of my hypertensive patients, looking for LVH for diastolic dysfunction, because of the clear association of the risk. And you can think about cardiac biomarker also that will increase your chance of detecting heart failure, and also looking for other peripheral arterial disease that will help you detect the end organ damage, and it will help you push more to control those patients and control the blood pressure early enough, and not just leave the patient without control for a long time. And if we look at this slide, I'm not going to read the whole figure, but the idea is you have a lot of patients that need more than two medication to control their blood pressure medication. Actually, most of the patients require more than monotherapy. And if you look at the clear clinical practice, probably a lot of them are not using this, and a lot of physician inertia that will kick in and will make the doctors prevent the patient from the benefit of the disease, and shy away from adding more medication to the patient to help control their hypertension therapy. we do have a lot of choices that we can use. I'm not going to go through all of them, but you know that we have the ACE inhibitor, ARB. They both act on the renin-angiotensin system pathway. We do have the diuretics, especially the thiazide diuretics, because they are potent in controlling the blood pressure, and we're using them a lot. They are one of the cheaper medication, and sometimes we reach for them, especially in the younger population. Be careful a little bit with the elderly because of the possible side effect profile. Calcium channel blocker is also another medication that we can use. Steroid polymerase is one of the older medications that we use, and with good effect in some of the patients, especially the patient profile that will you suspect having high aldosterone activation. Beta blocker also is one of the medication that sometimes I add, not just for heart failure patient, but also some of the younger population with oversympathetic activation. And it will help you control the blood pressure and will help you control your readings. So combination is key to control the blood pressure. We do have many other classes of medication that we can use. Centrally acting medication, the alpha blocker. I think a lot of our colleagues from nephrology probably use those medication. Vasodilators like hydrazine, one of the medication that we can use. Non-steroidal MRAs, the ARNI, which we use sometimes in heart failure patient, not necessarily just the HFrEF. I know we have less evidence, or not less. The evidence is not as strong with the mild reduced and the HFpEF population, but a lot of the HFpEF population will have difficulty controlling the blood pressure, and ARNI seems to be a little bit potent from that aspect. So it's not a bad medication to start the patient on. Loop diuretics is not the greatest in terms of controlling blood pressure, but they can be used in setting of the volume overload sometime. But the idea is we do have a lot of options, and we do not start the patients usually in clinical practice early. We do not combine medication early. We don't achieve target usually early. So, and as I talked to you from the slides before, leaving the patient with uncontrolled blood pressure over time will increase your chance of having a complication, as I mentioned before. I think this is my last slide. This is an older study, and I'm not gonna comment about any. I think it will have a good data, although it's old. Basically, it will show that in a controlled setting, this study was done in a controlled setting. The phenomena is patients usually take long time to achieve blood pressure control, and actually not all of them will achieve that control. So it will take longer time to reach the target blood pressure, and that's in a structured environment. So if you can take this into the real world clinical practice, I don't think a lot of the patients are using the medication appropriately and not reaching the target appropriately in a appropriate time. So looking at your patient in the practice, waiting for a very long time will prevent your patient from the benefit and probably will give them more harm by having the side effect profile. So at the end, as I mentioned, hypertension is a highly prevalent problem affecting significant population globally and in Saudi Arabia. It is a key driver to cardiovascular and renal complication. Stricter control improve outcome that's shown in major trials, and yet many patients remain uncontrolled, largely due to treatment inertia and delayed intensification. Thank you very much.
Thank you very much, Dr. Jleidan, for this very nice overview and approach. And it does highlight the importance and many aspects. I would like to ask all the attendees if they have any questions to put it in the question and answer section so we can discuss it in the discussion section at the end. But for now, I would like to invite our second speaker, my dear colleague, Dr. Ibrahim, Dr. Ismail Ruslan, who is also a consultant heart failure cardiologist at King Saud University, to talk about not all hypertension is the same. So please, Dr. Ruslan. You're mute, Ismail.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Prof. Walid, for this introduction. And I extend also my thanks to my dear colleague Ibrahim Jleidan on his excellent presentation. So I'm here to tell you that not all hypertension is the same, and that applies for many reasons. Most importantly, when we're talking about the awareness and the treatment and the control, there's a big variation irrespective of the gender. So if you look over here on the top, it's males, and the bottom, it's females, and you look to appreciate there is a variation in awareness, treatment, who's actually controlled and who's actually not controlled. But this also becomes much more apparent when you look into different phenotypes and different variants, so such as your ethnic category, your age category, and this is something that Dr. Rahim has alluded to earlier, and we appreciate that on our daily to daily practice. Establishing a diagnosis is not so hard these days, but it's also making sure that your patient is reaching their targets when it comes to good blood pressure control, but also the process where you ensure that you're preventing second organ damage, not necessarily picking it up. And that's where this holistic approach that demonstrates that they are not all the same, not only before you diagnose them, but even after you proceed with that. Another thing is when you look at the estimated 10-year risk of total cardiovascular disease using the prevent CVD risk equation that is stratified by blood pressure, you can clearly appreciate at the top it's males aged 55, and on the bottom it's females aged 55. The higher the blood pressure is, the more likely these patients are to have cardiovascular risk in the next upcoming 10 years. Now, patients are still not achieving blood pressure control despite guideline recommendations and the use of antihypertensives. So you make the diagnosis, you know what you need to do, but despite that, there are still barriers that are not helping achieve that. So in over 1.28 billion adults worldwide with hypertension, it was found that the majority of these hypertensive patients, about 80%, are still uncontrolled. So that's a blood pressure that is over 140 over 90. And only 22% remain controlled despite antihypertensive treatment. And the WHO projects that the global rate of hypertension control to be about 25% by 2050. But we need to thrive for more adherence and for more control. And this is the essence of these talks and these educational webinars that we have. But this is the essence of the discussion, not only with the healthcare system, but also with our patients themselves, because we want to ensure that, again, your diagnosis is not the same, but also your management is not necessarily the same. And also, our goals might not also be the same. Now, uncontrolled hypertension is associated with increased risk of many things. So if you look at the at hypertension contributing the cause to death of almost 250,000 Americans, that's back in 2022. And if you look on more data, you'll find that there's increased risk of mortality. There is cardiovascular specific mortality and heart disease specific mortality and cardiovascular disease specific mortality that exponentially increases as basically the hypertension is not controlled. Now, when people are on treatment, some of them are still not achieving targets, and those are the people who we call resistant hypertension. And these treatment-resistant hypertension vary from discipline to discipline and vary from registry to registry, from somewhere about the 10 to the 20, and it could go up to higher depending on certain ethnic groups. But at least when we're talking about a diagnosis based on the American and the European guidelines, they somewhat agree that your blood pressure needs to be elevated and you need to be on at least 3 antihypertensive medication that also includes a diuretic if possible, along with other measures. And there are common themes that you appreciate in these patients. Other risk factors, older age, certain ethnic populations, other comorbid conditions. But ultimately, and that's the most important thing, is when these patients with resistant hypertension are not getting their blood pressure controlled, the risk of other complications also increases, such as heart failure, end-stage renal disease, ischemic heart disease, and CVA, and death in these patients. Now, Aldosterone dysregulation is also prevalent in these patients with hypertension, and it's also commonly seen in other type of risk factors such as patients with resistant hypertension, obesity, diabetes, sleep apnea, and also in patients about 30% of the time is when we find some sort of aldosterone dysregulation. Dr. Ibrahim already alluded to a stepwise approach to managing hypertension. But again, these stepwise approach is not a one-size-glove that fits all. And there are certain things that needs to be taken into consideration while you're addressing your patients. Now, when you look at aldosterone and hypertension and basically cardiovascular risk and CKD, you realize that there is this discoupling that happens. And when you're looking at aldosterone, so serum aldosterone concentration and plasma renin concentration in a hypertensive patient, what happens is they become discoupled. So your aldosterone level starts going up and your renin level goes down. And if you notice over here, the risk or the hazard ratio of incidence of cardiovascular disease is exponentially associated with how high your blood pressure is, but also how high your aldosterone level is and how low is your renin angiotensin or your renin concentration is in your patients. And the other thing that you also appreciate is the systolic blood pressure difference treatment in patients with baseline high levels of aldosterone concentration versus those patients with non-high baseline levels of aldosterone concentrations, they respond very differently. So for the same group of patients, on the top left is patients with high aldosterone concentration versus less aldosterone concentration. And you can tell despite therapy, so placebo low sodium, ARB low sodium, ARB hydrochlorothiazide, ARB hydrochlorothiazide, and low sodium, there is still a statistically significant difference on how these patients are responding to blood pressure lowering. And this is not foreign to this audience, but I really wanted to stress the importance of the RAS system or the renin-angiotensin system in normal physiology before we go into abnormal physiology. But really in a normal person, so for example, if you're dehydrated, if you've had a very long day at work, you had no access to water, your renin-angiotensin system is there to help you, especially when we just came out of Ramadan. So essentially, when a blood pressure reduction is noticed or there's a decrease in sodium in your body, your glomerular system starts by releasing renin, which in turns goes into the angiotensin cascade to angiotensin 2 with its vasoconstriction properties, along with the promotion of the release of aldactone, which of aldosterone, which in turn results in water and sodium resorption in your patient and expands your volume and increases your blood pressure. And this is a feedback loop where elevations on blood pressure and sodium lead to inhibition of the renin release and decrease in the RAS activation and reduction in the aldosterone production on a quote unquote PRN needed basis. Now, what happens in aldosterone dysregulation, there is an abnormal aldosterone production despite a low renin and a high aldosterone serum in your patients. So what happens is you have this risk dysregulation where more aldosterone in your body results in more sodium and more water retention and more absorption and more expansion of your plasma volume in these patient populations. Now, one of the things we also appreciate is higher levels of aldosterone positively correlate with increased blood pressure, as we've seen previously. And this is an association between serum aldosterone concentration and systolic and diastolic blood pressure. As you increase your aldosterone concentration, the blood pressure also goes up. But not only that, the increase in aldosterone levels are associated with an increase in blood pressure and new onset hypertension. And this is here appreciated in different quartiles of of patients, and you would see the higher it is, the higher the blood pressure, and the higher it is, the higher likelihood they will develop new onset hypertension. And aldosterone levels parallel hypertension severity, as we've mentioned before. And over here, you see adjusted renin-independent mean aldosterone production by blood pressure category. So in looking into untreated normotensive patients, stage 1 and stage 2, and treated resistant hypertension, you would appreciate that the 24-hour collection is higher in patients with resistant hypertension, and this exponentially increases as the blood pressure also is noted in this study. Dr. Ibrahim has also commented on the general effect of hypertension on the body. And if we zoom in on aldosterone, aldosterone affects many things. And there are direct effects that are related to blood vessels that causes excess vascular remodeling and fibrosis leading to CV damage, effects on the heart that causes also remodeling, hypertrophy, and also affects function and increases cardiovascular morbidity and mortality, and also the effects on the kidney itself, which influences fibrosis and inflammatory changes along with proteinuria and basically leading to kidney damage. Now, as we mentioned, aldosterone exhibits its effect not only through the melanocorticoid receptor. So there are different ways where you can have effects, but ultimately you're having pathological remodeling. So primarily we're talking about melanocorticoid receptor or classic genomic effects, and that basically alters the expression. But there are alternative receptors that could also be directly affected by aldosterone, such as the GPER1 as well. And these interactions collectively lead to endothelial dysfunction, kidney dysfunction, atherosclerosis, and inflammation, and end organ fibrosis. And if we look into the Pathway 2 study, so the Pathway 2 study was a double-blinded placebo-controlled trial of about 335 adults with uncontrolled hypertension. So it was more than 140 or more than 135 with diabetes and basically 3 antihypertensive medication at the maximally tolerated dose. And they look to see the effect of adding spironolactone on blood pressure control in comparison to other therapies such as bisoprolol and also dexamethasone. And what was noticed is it was very effective across the baseline plasma renin concentration in reducing the blood pressure in comparison to bisoprolol and dexamethasone in patients with resistant hypertension. And really, the Pathway 2 is what helped also shine light on the importance of considering an aldosterone antagonist as part of your treatment regimen for blood pressure control. And as you are aware, and as previously Dr. Ibrahim has mentioned, there are different therapies that are available for us and they target different things. We talked about the pathway when we talked about the renin-angiotensin system, primarily having your ACE inhibitors, your ARB, and also when we talk about the aldosterone pathway, primarily a melanoreceptor antagonist is another pathway that basically blocks the activation of aldosterone on the receptor. But also, on the other hand, it is associated with increased circulating levels of aldosterone, and also it might induce a renin-dependent controregulatory increase, as we have previously mentioned. The other thing about MRAs, they don't fully inhibit the effect of excess aldosterone, as we mentioned, because while MRAs block melanoreceptors, they prevent binding and activation by aldosterone. They're only involved in 50% of aldosterone signaling. Therefore, they don't completely inhibit the effect of excess aldosterone. Steroidal MRAs, as you are aware, can cause significant adverse effects, and this includes hyperkalemia, libido loss, erectile dysfunction, gynecomastia, and amenorrhea, leading to low rates of persistence. Also, the MRA can induce counter-regulatory increase in aldosterone that might limit their effect as well. So new therapies are needed to fully address the effects of excessive aldosterone, and aldosterone synthase inhibitors can be an alternative to MRAs for the treatment of patients with hard to control hypertension. There was a paradigm translational shift because there's a big difference between knowing what you want to do and what you can do. And this is the essence of selective inhibition of the aldosterone synthase. The reason being is the chemical sequencing of the aldosterone synthase shares 90% structural similarity to the enzyme that controls cortisol synthesis. So that's the 11 beta hydroxylase. And that makes it very difficult to develop an aldosterone synthase inhibitor that does not also inhibit cortisol synthesis. And the selective inhibition of aldosterone synthase will avoid the off-target side effects due to reduced cortisol production. And that is really the essence of having specific aldosterone synthase inhibitors. Now, as we've mentioned before, there are two mechanisms of an aldosterone pathway. There's an upstream and there's a downstream pathway. And when you're blocking aldosterone at the level of the receptor, that is a downstream obstruction. What we assume and believe is even better is when you have an upstream basically inhibition by basically blocking the aldosterone synthase. You don't only block the receptor, but you also block the production altogether, and you look and you mitigate on receptor-related side effects or receptor-related effects and off-receptor-related effects by accumulatively decreasing the aldosterone level. And as we mentioned before, hypertension is not all the same because the diagnosis is not all the same. And when we're talking about whether you're making a diagnosis or even if you're contributing a diagnosis of resistant suspected hypertension, there's a lot of pathways that you need to go in, and there's a lot of individualization that needs to be taken into account, such as pseudo-resistance. Are they taking their medication? Are they the right medication for them? Are there secondary causes of hypertension that needs to be addressed? And the management is different based on different stages. Your goals are also different, and that tells you why hypertension is not the same. Also, in the same circle, you would notice that there are different phenotypes, and that's something that we have alluded on previously. But your treatment plan and your management also varies depending on your patient phenotype, from a first line to a second line to a third to even contraindicated. Because it's not as pure as hypertension and CKD. Sometimes there's an overlap. So hypertension, diabetes, hypertension, CKD, coronary artery disease, stroke, HFpEF, HFrEF, and high tachycardia and obesity. And that is the role where a collective multidisciplinary team approach is cardinal in addressing these patients. So in the end, I'd like to end where I first started by telling you that not all hypertension is the same. This applies for diagnosis, this applies for your management and your up titration, and also your algorithms that you are choosing and the treatment plans. Thank you very much.
Thank you very much, Dr. Ismail. Very interesting overview of the treatments and the pathways. Added a lot to our knowledge. And with that, I think we have a lot of questions, mashallah, that are touching on several of these aspects. Many of, or a couple of questions actually, complaining about the absence of combination pills, so combination medications in many of the governmental hospitals. Dr. Ibrahim, you mentioned how important that is to help patients with the compliance in blood pressure medications. Do you have any comments on that? Any advice? How can we go around it? Is it pure financial?
Yeah, I think it's pure financial because of the price of the medication itself. But I think if it's looked at from a different point of view, from increased compliance to the evidence behind it, like many of the major trials, the ASCOT, the Accomplish trial, the Triumph trial, I think all of them use single pill combination double therapy or quadruple therapy. And the guideline actually recommended those medication. And you can see, like, especially elderly patient, they come with like a 20 pill And if I can usually decrease the burden of the pills by combining medication, I use that also with the statin, ZMI, for example. Like taking four different pill to only couple or one pill that will make life easier. It's good for compliance. It's actually in the guidelines. So I think it's just the matter of the price. And I usually, uh, depending on the patient, if they can offer the combination, if they don't have insurance or something, I usually advise it. But unfortunately, yes, in most of the governmental hospital, they don't have it.
Yeah, that's true. So here, Dr. Ismail, you mentioned, talked about the aldosterone dysregulation and the role of treatments. The question here is about finerenone. What's its role and when is it indicated?
So, if we were to look at finerenone per se, uh, based on the current data we have, its role is primarily in cardiorenal protection, and it has modest blood pressure lowering. And the other thing when it comes to it is it hasn't been studied yet in resistant hypertension up to my control.
Yeah, that's true. And another question I might also ask Ismail. You talked about this regulation. Is it recommended to measure renin aldosterone ratio in every patient with hypertension or resistant hypertension? And what about measuring cortisol as well?
Great. So when it comes to whom to measure, and in other words, whom should we start suspecting secondary causes of hypertension, the American guidelines and the European guidelines really help manage this. The short answer is it should not be measured routinely for every hypertension patient, but we should have a low threshold to test certain patients. So patients who have drug-resistant hypertension, patients who are young of age, primarily that are younger than 30, patients who have been previously controlled and then all of a sudden the blood pressure has started controlled, being uncontrolled, patients who have a malignant or accelerated course of hypertension, and patients who have evidence of diastolic hypertension that are at an older age. And also looking for other findings such as unprovoked or excessive hypokalemia in these patients can be another marker to look at it. You commented on about high cortisone, I believe. So high cortisone is another thing that was noticed. There was a trial, um, momentum trial that basically looked into seeing whether patients with hypertension have high cortisol level, and about 25% of these patients had high cortisol levels again. And this points you again to the finding there about 1 to 4 patients might have an excess in cortisol. But again, this is still exploratory, but that brings you back to managing your resources and deciding which level of the spectrum are you when it comes to diagnosing and managing hypertension. Are you a primary or a secondary or tertiary center? And you provide the care and the diagnostics that are available for you as your patient is progressing through their hypertensive journey.
Excellent. Dr. Ibrahim, you talked about the approaches to management. There's a question here about the role of renal denervation and where it stands nowadays.
Yeah, so renal denervation is an add-on tool, if I can put it this way. So there was initial hype about it initially. There was like an conflicting data. Then we have a little bit of a positive recently trials, the spiral hypertension trial, radius trial, I think. They have it seems like a little bit variant reduction. Some of them try to suggest 4 to 6. Some of them reach up to average of 6 to 8 millimeter mercury, reducing ambulatory readings. The guideline are putting them now as a class 2B. So the American guideline, the one in 2025, putting it as a class 2B for people who I think, and that also agree with the European guideline. If you have a person with resistant hypertension, so basically your office blood pressure or ambulatory blood pressure above 140/90, you're already on multiple therapies, or you are intolerant to therapy. So, for example, there is a side effect or significant side effect profile. Then it's one of the options that you can discuss with the patient. It does seem that the side effect profile is very low. It's especially with the newer catheter. I think the incidence of complications are really rare. I think some of the studies there were like zero side effect, which is usually rare to see with an intervention usually. So I think it's a useful tool to have. It's not the first one to reach at this stage, and it's not one. I think there is a little bit of a hype about it sometimes, but for example, some of the newer medication will have probably stronger add-on reduction rather than the RDN, but it's one tool that we can utilize.
I think one important factor is I think it's operator dependent and depends a lot on the device itself and the experience. And we have to note that, as you said, it's an add-on most of the time when you've already reached 4 or 5 medications, and most of these patients will not stop the medications. It would just probably help in the control. Dr. Ismaili, there's a question here about diastolic blood pressure. Should we worry about diastolic blood pressure in patients with isolated systolic hypertension? Is it something that you take in consideration when you manage your patients with isolated systolic hypertension?
So again, I think that's isolated diastolic hypertension is less common, and but it's still seen, especially in basically different age populations. And you see it more oftenly in younger agents, some younger patients with high sympathetic tone, but also it can be a marker of early hypertension phenotypes as well. So I would still, in these patients, recommend to follow the guidelines when it comes to systolic and diastolic cutoffs for making a diagnosis, but also I would consider it as your trigger to an ongoing elevation in systolic and diastolic hypertension.
So the question was about isolated systolic hypertension, and I think the worry here, especially in patients with probably coronary artery disease, where your coronary artery flow is mostly in diastolic, so you don't want to go too low, especially below 60 in these patients for the diastolic blood pressure. That's probably just the way how to weigh it and make sure that you treat your systolic hypertension, but don't drop your diastolic too much. You might need to tolerate a little bit higher systolic, so you don't get more side effects from the diastolic hypotension. I think that's the Ismail, let me go to Brian. Severe aortic stenosis. It's a delicate situation when you have hypertension in these patients. What would you do?
Yeah, so the problem with the severe AS obviously have a fixed obstruction. So you're concerned about lowering the blood pressure too much because you can tank the outflow for the patient. So I think it's probably with those patients, it's a temporary situation. You should now, we have a lot of ways to fix the aortic stenosis, but I think we do have good data on ACE inhibitor being one of the probably safest medication in this approach. Beta blocker, if they have also concurrent coronary artery disease, avoid some of the potent like nitrate probably and diuretics in those population, and probably go slow with those patients and maybe a little bit lenient on the target. We don't need like less than 130/90, probably like keep them in the 130s, like 80s range is fine. I'm definitely looking at the core problem, which is the AS, and fixing that will be the key in those patients.
Right. Ismail, one of the points that always confuses me personally actually is measuring the blood pressure. Most of the studies are built on well-structured measurements in a calm area, repeated. Practically, it's quite impossible in our clinics. We do tend to go for home monitoring, for 24-hour blood pressure monitoring, and these things. What's your view in that? And if I'm going to ask my patient to monitor his blood pressure at home, what's the best approach and the best time for that? You're mute, yes, ma'am. You're mute.
Can you hear me now?
Yes.
Yes. So essentially, that's one of the things we struggle with as well. And, the one liner is hypertension usually is not a diagnosis that takes place in the clinic. And the best and the gold standard is the ambulatory 24-hour day and night blood pressure measurement because it gives you other features that are also important. Because as we are aware, there are other things that we're looking for, not only the average blood pressure, but we're looking for these small nuances such as a dipper or a non-dipper, because these can also help you decide about your risk of cardiovascular disease. But also, I find it very helpful because we sometimes stress the patients when they are in our clinic, and I find these measurements at home really help. So my choice is usually an ambulatory blood pressure or home blood pressure management for our patients. And the way it's actually done is really simple. And we would follow the guidelines from the AHA and from the European Society, where you would either put an ambulatory blood pressure or you would basically send them home and instruct them with a diary to have repeated blood pressure measurements about 3 times per day for 5 days at least. And then you would come back and review to see the average of these blood pressures and the averages of the averages. And based on that and based on the thresholds and the guidelines that you follow, you would make a diagnosis of hypertension.
Nice. So now you diagnose your patient and you start him on treatment. How would you ask him to continue monitoring at home? Should he monitor daily? Should he monitor once a day? What the best time for him to take his blood pressure at home?
So essentially, there are two pathways. I'm looking for general day-to-day control. So at least we would ask our patient to measure their blood pressure once daily. And that is primarily once they are stable. And once your patient is in the treatment phase, then you want to make sure that, or what we call in the steady state, you want to make sure that you don't have repeated fluctuations in blood pressure. So in the beginning, when we're in the adjustment phase, as Dr. Brahim mentioned, it's these repeated visits of repeated blood pressure measurements about 3 times per day for several days, and then you come to me to the clinic until we reach target when it comes to your blood pressure control. But whenever we've reached target, daily blood pressure measurements or repeated blood pressure measurements are not routinely needed. I would caution my patient about the fact that prior to visiting us in the clinic, I would usually ask them for a log of at least the 3 days before for 3 times a day, just to get a sense of how where their blood pressure control is.
Thank you. Now, Ibrahim, do you believe that we need hypertension specialists or specialized hypertension clinics for some patients at least?
Yeah, so I think it's a huge problem that I don't think we can just manage patient with advanced center. I think still family physician, internist, and general cardiologist is going to be still the cornerstone of hypertension management. But having a certified hypertension specialist, a center of excellence, I think it's increasingly recognizable. It's needed, especially with some of the workup of the secondary hypertension, for example, some of the introduction of the new approaches like the renal denervation. It probably will help with the physician inertia and increasing the utilization of medication. I don't think it's going to be enough to manage all the patient, but I think having a center in each area, for example, in each cluster, if they have one clinic that's specialized, that can accept certain patients who are really difficult to control, who need the workup, who need more intervention, I think that's very reasonable. To be the cornerstone of the management, I think is difficult. It needs to be more broad than this.
I think it's a shared problem from the family physician to the internist, cardiologist. Everyone has to maybe the difficult patients or the the resistant patients might need some special care, but as a general, I think it should be a shared approach. Mashallah, there are lots of questions. I'm sorry we're not going to be able to cover it all because of the sake of time, but I might take one last question. Dr. Ismail, aldosterone synthesis inhibition, what treatments do we have? Is there anything coming soon to tackle that pathway?
Great. So currently there is baxdrostat, and baxdrostat is a medication that is taken orally. It comes in two doses, 1 milligram and 2 milligram. And this was recently published in a trial that was published in the last ESC in the New England Journal of Medicine. So that's one of the aldosterone synthase inhibitors that is gaining accelerated FDA approval. Inshallah, Saudi Arabia might be one of the first to have it actively available.
Yes, and I heard that it was already approved in a neighbor country, and hopefully, as you said, soon will be approved, inshallah, in Saudi Arabia. Again, thank you very much, both of you, for this very amazing talks and discussion. Before we leave, we're going to show a code, a barcode, please. If you can scan it for a survey. I do thank AstraZeneca for sponsoring this meeting and for making it possible in collaboration with the Saudi Heart Association. So please, for the attendees, if you could scan this barcode, short survey, it would be very helpful for us. With this, I'd like to thank you all again, and looking forward to see you in future events and talks, inshallah. Thank you very much. Assalamu alaikum wa rahmatullah.
Thank you very much.